Welcome to the Dementia Care on Air podcast series. I'm your host, Anna Chodos, the Executive Director of Dementia Care Aware. The goal of this podcast is to bring you short educational moments that will help you detect dementia and care for people living with dementia. And we're especially focused on how we do that in the primary care environment and the real world. We're going to have a lot of information that mimics what we have on our website and in our other educational modules. But we're also going to have conversations with experts and other people in the community in the field of dementia care that just help us do a better job in caring for people living with dementia and connecting them and their care partners to the things they need. Welcome, everyone, to the Dementia Care on Air podcast. Very excited today to have our topic, Brain Health Plan, how we can implement a brain health plan with our patients and their care partners, the evidence for it, and different strategies that we can use. I'm very excited today as well because we're joined by Dr. Ian Neel, who did our webinar on this topic in July. So I encourage you to take a look at that as well. But today we're going to have a brief and engaging conversation about how we can implement these brain health plans with patients. And so first, I'd like to say welcome to Dr. Neel and have him introduce himself briefly and tell us a little bit about the work that he does.
Yeah, absolutely. And thank you for having me today, Dr. Chodos. So I'm a geriatrician here at UC San Diego, and I work in several facets here. I work as a consultant at our memory disorders clinic, where I see patients for intake and initial evaluation for cognitive complaints, as well as our senior behavioral health inpatient psychiatry unit, where I serve as the medical director of the geriatric consult side. And we run a co-management service there along with psychiatry, helping to take care of patients with behavioral issues in the context of memory problems, as well as other psychiatric issues.
Great. Thank you. That's incredibly important work, and just really glad to have your expertise today. I know you're also really passionate about brain health, how we can prevent onset of dementia, and how we can also just improve brain health if people are starting to have symptoms or have a diagnosis. So let's dig in. I'm thinking it'd be great if you could just kind of outline, when you say or think about the term brain health, what are you thinking about?
Absolutely. It's a difficult concept because it's so all-encompassing. Really, when we're talking about brain health, we're talking about this connection between the mind and the body, and doing what we can to help preserve our cognition through ways in which we're addressing physical health, through ways in which we're addressing the mind and mental health. Everything that occurs within our body can affect our brain positively or negatively, and doing what we can to try to optimize that can often optimize our cognitive health. And we have found that there's a lot of evidence that shows that the more that we can focus on this kind of meta health of our body and our brain, the better off our cognition tends to be. And it can help even prevent the onset of dementia, or even in those who are developing dementia, can help slow the progression of that.
Yeah, this is something that really gets me motivated to talk about it as early as possible. The patients is realizing that a lot of the same things that are classified as risk factors for developing dementia, having incident dementia, addressing those risk factors are also the same components that we might see in plan to help reduce progression. So definitely, as part of the Dementia Care Aware initiative and really trying to emphasize early detection, I know the opportunities to address brain health are a big reason that I think it's worth it.
Absolutely. And I mean, that's the thing that really has excited me about going into dementia care is, I frequently get, when I tell people outside of geriatrics that I do dementia care, the response I usually get is, "Oh, isn't that so depressing?" And to look at the loss of consciousness, the loss of self, of course it is. But if we can do things to help prevent that, all the better. And that's kind of the thing that really motivates me every day to take care of patients in this line of work. And, as providers, we often get so fixated on the medications of, oh, you've got dementia, so here's your donepezil, or here's X, Y, and Z med. But the benefit of those is relatively small. And there's often a lot greater benefit to these non-pharmacologic interventions. And so through addressing that and through helping discuss that with patients, we can often enact a much better outcome in terms of protecting cognitive health long term. And so that's the thing that I find is not depressing about this line of work, but really uplifting, is being able to have those interventions and discussions with patients.
Oh, that's awesome. Yeah, even I like that you also said even better than some of the other more medicalized interventions that we have, or, strict medications and things like that. So let's dig in. Let's talk about how you structure a brain health plan for your patients. And are there big buckets that you think about as being like the main areas that you want to have a care plan for? So yeah, what does that brain health plan start to look like?
Yeah, definitely. It all starts, I feel like, with this connection between the mind and the body. And so, whenever I'm seeing a patient for initial cognitive evaluation, I'm always assessing what other medical conditions they happen to have. And are those medical conditions optimized? And are they medical conditions that should be optimized? Through addressing physical health issues, reducing risk of things like high blood pressure and diabetes, and getting good blood sugar control. All of that can sometimes have dividends in terms of just giving a better baseline physical state of health. So I always say it starts with that umbrella of physical health. And then beyond that, kind of the big bucket, so to speak, to really focus on, I'd say if you can focus on at least three, because we all like things in three, right? If you can focus on at least three things, the big three, I'd say, would be to do what we can to address polypharmacy, to do what we can to address physical activity and physical exercise, and then to do what we can to address mental activity. There are many other things that you can do beyond that through addressing vision and hearing and assessing for reversible conditions, through nutritional optimization, through socialization. But, I'd say probably the three that give you the greatest benefit for time invested would really be polypharmacy, mental activity, and physical activity.
Great, because I think you're right. I think we can remember three things, and digging in on those three areas. Polypharmacy, how do you think about that, and what are your targets for improving? I think especially as geriatricians, we're very primed to just in general look at medication burden and the schedule and what meds are on there. But when in this context of brain health, is there a particular way that you approach polypharmacy?
Yeah, definitely. As geriatricians, we always want to change the world and fix everything. And unfortunately, through polypharmacy, it's often overwhelming, because it's like, where do you start when you have your patient coming in on 35 different pills that they've been prescribed in increasing quantities over the past 30 years of their life? And where do you even begin in terms of reduction? Well, what we know is that polypharmacy itself just means too many meds. And if you can reduce that overall pill burden, that has actually been associated with better cognitive health. Is it really the cocktail of pills and the number of pills, or is it more the way those pills interact? It's kind of up in the air, and we don't have a discrete answer for it yet. But we do know that kind of the more pills you take, the higher your incidence of cognitive impairment as time goes by. So reducing that overall pill number can help. But when we're looking at pills and looking at things to potentially cut back on, to potentially stop, the kind of biggest enemy of cognition is anything that blocks acetylcholine, because that's how our hippocampus works, is through the neurotransmitter acetylcholine. And so if we can boost that and not block it, great. And there are a lot of medications that have anti-acetylcholinergic action. The classic one is Benadryl. It's, why every geriatrician in the world bristles the moment you even mention the name Benadryl. And it's because it's a very classic anticholinergic med. And it works great for things like allergic reactions, works great for allergic rhinitis, but it comes at a cost because it's got a very high anticholinergic action, similar to the action of atropine, which is kind of the gold standard anticholinergic med. But there are a lot of medications that have anticholinergic burden that we don't necessarily think about. And so trying to look at a patient's medication list, see which medications on there have anticholinergic action and reduce those as much as possible, either by stopping them if they're non-essential or transitioning them to something different that doesn't have acetylcholinergic action if they are essential, can often help our patients out quite a bit. There are tools out there that can help you for this. There are many anticholinergic burden index calculators that are available online. Each one has their pros and their cons, and there's no one that's like perfect. Many of them are missing one drug or another. But when you collectively look at them, you can often start to get a sense of what are the most common medications to be concerned about. And so, if you can help reduce the anticholinergic medications of your patient, that's usually, from a cognitive health standpoint, the best starting point.
And when you're getting these scores, you're trying to remove a medication, or you're trying to remove an amount, or kind of either?
Kind of either. What we know is that if you've got an anticholinergic burden score of 3 or greater, that's associated with increased incidence of cognitive impairment. And so overall, we're trying to lessen score to less than 3. All these anticholinergic burden scores have been come up with based on looking at different drugs in the lab and just comparing how much they bind to the acetylcholinergic channel compared to atropine, with atropine being the gold standard, and all drugs get then subclassified into a score of 1, 2, or 3 based on how anticholinergic they are compared to atropine. Anything with a score of 3 is comparable, 2 is about 50 to 60% as anticholinergic as atropine, and 1 is small in the 20 to 40% range. And there's a little bit of variability in the scores of 1. So, when I'm looking at a patient from cognitive health, definitely anything with a score of 3, those are the ones I want to try to stop. Those are the ones also that we most commonly think of as anticholinergic. Benadryl's on there. Most of the traditional antihistamines are on there. And all of the urinary incontinence meds, most of which operate through antimuscarinic action, are also on there. So, those are sometimes the easier ones to stop. Scores of 2 are less commonly prescribed medications. It's a lot of atypical anti-seizure medications. Some of the mood stabilizer medications show up in there, as well as some anesthetics, things that we don't typically wind up prescribing too much. And then the score of 1 is the kind of interesting area. In the area we often aren't able to necessarily stop, but if we see a lot of score 1 meds, it makes us more likely to stop medications that have a score of 3. There's a lot of unusual meds in the score of 1 that we don't think of as anticholinergic, but actually are. Metoprolol, Coumadin, lisinopril all have an ACB score of 1. So, typically, say you've got atrial fibrillation and heart failure with preserved ejection fraction. Almost for sure, you're going to have a minimum of an ACB score of 5 just by the medications you need to be on from the cardiologist to treat those 2 conditions. So, we may not necessarily be able to stop those medications, but it's going to make us a lot more likely to not prescribe an ACB score of 3 medication if we're already on those.
Yeah, I can add up quickly. Then everything. We're sort of having that informed conversation with patients and their other doctors. But it does sound like it's good at least to be aware and to not pile on. So that's really helpful. Do you have a way that you sort of present why we're deprescribing or changing a medication to patients in this context?
Yeah, absolutely. And I usually present it to them kind of like I just have, is that, these are what we know is that all of these medications have a purpose, but every purpose has a double-edged sword of potentially a risk associated with it. And, as much as we can lessen the amount of medications that you're taking, and as much as we can substitute medications that you're taking for ones that are less cognitively detrimental, the better off your memory is going to be. And usually when I put it that way, I don't face any resistance from the patients in doing it. Usually the second that I mention you're on too many medications, the patients are almost for sure agreeing and asking to stop medications. Nobody wants to be taking 13, 20 pills in the morning. And so I find that in clinical practice, it's pretty easy to stop the medications and to get patient buy-in to stop the medications. I think sometimes the harder thing is convincing your colleagues of why it's important. Everybody wants their special med to, of course, be necessary and to not have any side effects associated with it. So, sometimes convincing the cardiologist as to why we may want to reconsider the Coumadin for AFib and maybe substitute that for something that doesn't have anticholinergic action, but also can work as a blood thinner. Sometimes it's a harder conversation, but it's just a matter of, I find, A, reaching out and discussing, and B, also partnering with primary care. And primary care can often be a great benefit in these types of discussions, because really they're the only ones in a patient's care that's truly looking at the whole patient, that is taking all these different subspecialist recommendations and helping the patient to decide, well, you got 5 different docs all telling you different things based on your interests and your concerns. Here's what we really need to care about. And so, really partnering with primary care is, I think, the most important thing in getting successful polypharmacy reduction to happen.
Yeah, well said. And I'm really hoping that, some primary care providers and ancillary staff are listening and feel like this sort of information is helpful, or at least, the approach. Well, great. Well, that was thorough and really helpful. And so what about physical activity? How do we approach encouraging people to create a physical activity plan that really supports brain health? And are there sort of pillars or principles there that are different than, other reasons and ways that you would recommend physical activity?
Yeah, definitely. It's probably the hardest one to discuss, and everybody's eyes glaze over the minute you go to your doctor and your doctor says you should exercise more. I always say it for every medical condition under the sun, that exercise is important. And so trying to get past that, sure, I should exercise, I'll think about it, to I'm actually going to exercise is probably the hardest part of my job. And it really depends on each patient to kind of how we can discuss physical exercise in a way that's going to motivate them. In my kind of intake realm at our memory disorders clinic, most of the patients that I'm seeing are coming in for initial evaluations of memory problems. And I find that that's kind of a good time to kind of use that as a motivating factor. It's easy to say exercise, it could prevent you from having a heart attack or a stroke in 10 years. People are like, okay, that's 10 years from now. But when you're saying, hey, you're coming in and you're already concerned about memory, and you are concerned enough that you're seeing a memory specialist, maybe we should do something to actually try to prevent you from developing memory problems. And one of those big things is exercise. Sometimes that can be the motivation, I find, to get people to think, maybe now's the time to start. And then, the problem becomes there's a lot of things that are recommended for exercise that have been shown in the literature to be associated with a reduction in risk of cognitive decline, as well as in prevention of dementia. And the problem is when you present all of that to the patients, that also can be overwhelming and get them to shut down. Is, if you go by the Surgeon General's recommendations for exercise, it's do 150 minutes of moderate to high intensity cardiovascular exercise a week, as well as do 2 days a week of 20 to 30 minutes of resistance training with weights, and to do at least one day a week of about a half an hour to an hour of some type of balance training. And when you present all of that to the patients, for somebody who doesn't exercise, it can be like, there's no way I can do that, and it just sets them up for defeatism. And so I find that what helps better is to say there's a lot of different things that are recommended for exercise, but hey, first let's talk about what you do for exercise already and see how we can augment that. And if I find that it is the patient that just sits at home and watch TV all day and doesn't do any exercise, I'm going to give different recommendations to them than the patient that's already doing some exercise. For that, I'm not exercising at all. I'll talk to them about all the different things that are recommended, but I'm going to try to motivate them to at least, hey, 2 to 3 days a week, get out of the house and go for a walk for half an hour. And if you can do that, you're already ahead of the game compared to your peers. And then once you're doing that, then on subsequent visits, hey, now maybe we could start pushing it a little bit more and increasing that exercise regimen. If I've got a patient that's falling all the time, and which is a common problem that we run into in geriatrics, I'm not going to be necessarily motivating them as much to go out and do the cardiovascular exercise component. I'm going to instead be talking more about, hey, let's see if we can kind of kill two birds with one stone and get a little bit of cardiovascular, but also get a lot of balance training, and maybe consider doing a Tai Chi class. And looking up Tai Chi classes in the area and see if you could at least get out once a week to your local YMCA or somewhere where they're offering a free Tai Chi class to do. Because we know that balance training is the number one thing that we could do to reduce our risk of falling. And Tai Chi is the best studied of all of that. Yoga also has been pretty well studied, but I find that Tai Chi is easier to do than yoga for some of our senior population, especially if they have arthritic knees or things like that. And if we can do that at least once a week, we're getting some cardiovascular. More importantly, we're getting the balance training and reducing the risk of falls. If I've got a patient that's already doing a lot of exercise, maybe I'm not even going to spend a lot of time talking about exercise, and instead focus more on the other interventions, such as mental stimulation. So it really just depends on the individual patients and their needs and their interests, how I make these recommendations to patients. And there's really no one recipe that fits all, but anything you can do to motivate your patients to do some exercise, the better off it's going to be for their mental health.
Yeah, awesome. I think similarly, in my approach, and have often said, like, inactivity is the real enemy here. That's the thing that really will harm your health. And so what does it seem like you could do, daily, even briefly, and then we can just kind of go from there. And I always try to keep the bar low for the first, homework assignment, if you will, and try to make it, seem time delineated, like, let's just try this before the next appointment and we'll see how we do. And yeah, all these sort of strategies you're talking about really like making it relative to the person and then making it seem more doable. That really resonated with me and is helpful. And I agree, like, we're all aware of the Surgeon General recommendations, but it can be kind of
daunting.
Yeah, daunting and seem like a really big lift.
Yes.
So, yeah, and I often refer to it as the magic pill too sometimes, and try to just point out that a lot of ways we don't know why physical activity is as good as it is for your body and your mind, but definitely it clearly has really beneficial impacts. So great. And it's just really great to hear how you think through really figuring out where your patient's at and how you would help them make moves, as it were, towards more physical activity. Okay, so then the last bucket you mentioned that we want to include in the brain health plan is mental activity or mental stimulation. And that one, I'm guessing providers and clinicians maybe have less of an idea of what to recommend. So what are the things that fit into that part of the brain health plan?
Yeah, absolutely. And it's definitely the most nebulous of all of the recommendations. And so it's the one that I find myself spending the most time talking to patients about. But I find that, it's the thing that probably, in my opinion, helps the most if we can get patients to engage in it. Really what the thing that I start out with is by talking about kind of what mental activity isn't. Everybody wants quick fixes. It's the same reason why people don't necessarily want to focus on these non-pharmacologic interventions. And, why exercise when I could take a statin for my cholesterol? Why exercise when I could just take donepezil for my memory? And the problem is there is no easy quick fix for cognition. And similarly, there's no easy quick fix for mental activity. But I often will talk to patients about this phenomenon called cognitive reserve of the more that we use our brain, the more that we force it to work through complex problems, to think about things, to process information, the better off our brain functions. And the more difficult that is, the better it tends to be. This is why we find that patients who have a higher formal education level develop dementia at later rates than those who have a lower formal education level, because we spend more time in school building up that cognitive reserve. If we're working, that also helps build up cognitive reserve. And people who work longer and retire at later stages also tend to develop dementia later. Again, just because they're kind of forcing their brain to continuously work through these problems. But when we just sit at home and vegetate post-retirement and watch TV all the time, it kind of tells the brain, hey, there's just no need to do all of this anymore. So it kind of gives up. And so we have to find something to force our brain to think and to work through problems in a similar way to when we were working or when we were in school. And so really what that is for each individual patient, it depends. And it depends on what their interests are and what their motivation is, as well as what their capabilities are. If I've already got a patient coming in who's got mild to moderate cognitive problems, I'm probably not going to encourage them to join a book club, because it's going to be a bit defeatist for them if they can't remember what they read to then discuss at the book club. And instead, maybe consider something like a adult day program, something that allows them to engage with peers and to interact with things in their environment, with people in their environment, work through problems, etc., in a kind of more formal and structured way. Whereas if they're more cognitively intact, then those are the ones that maybe I would recommend something like joining a book club, because joining a book club is a higher order cognitive activity, because you're not only having to read, but you're having to discuss what you read. So that adds that extra layer of understanding, and you're doing it with others. So it's encouraging socialization as well, which is another benefit in terms of cognitive health. And so I always say, half in jest, if nothing else, get a hobby. And it doesn't matter what that hobby is, but anything that falls into the category of a hobby is typically cognitively complex enough that it counts as mental exercise. There's multiple steps of checks and balances of thinking through problems and coming up with creative solutions. And so, really focusing on that with the patients and talking with them about that is, I find, the greatest benefit. The thing that I find that people often do is that they say, hey, play Sudoku, or, like download a memory game app. What we find is that those are not enough really to help in terms of mental activity. When we've looked at those in the studies, we found that, if you do a memory game over and over again, you're going to do better at that game over time, but you're not going to think better as a result. It's too kind of simplistic of an activity. So those are more kind of teaching learned pattern behaviors, almost like a rat in a maze. It's not doing things that are fostering kind of greater intelligence. And so I typically won't tell patients to do that and tell them, hey, if you're doing it and you like it, great, but don't put all your eggs in that basket. Really focus on things that are challenging your brain more.
So sort of like if people can feel they're working at something cognitively and learning, that's sort of one marker of something that's sufficiently engaging.
Exactly.
Okay.
Exactly.
Great. Well, I think that really helps kind of put an end to going over some of the big pieces of the brain health plan. Of course, there's so many interventions, there's such great evidence out there, but I really appreciate the way you were able to bring these sort of three big areas into focus and show us how it forms a brain health plan and kind of helps us work with patients and their care partners to help people living with cognitive symptoms or dementia and trying to prevent it, really foster this, what you were calling like the mind-body connection, the health of that connection so that, we're slowing progression. We're helping people live longer with milder symptoms. I know that's a really big goal for us when folks are already having symptoms. So I'm just going to quickly repeat it so our listeners can review it with us. But you sort of right out the bat, you emphasize the general mind-body connection and how physical health just generally is important, which I think probably will really resonate with most patients that if your other conditions are doing well, your brain will do well too. But then very specifically for the brain, we're going to focus on medications and polypharmacy, specifically anticholinergic burden and how to optimize that for whatever else is going on as well. Encouraging physical activity, and that's going to be something relative to that person and where they're starting and what they can do. And then mental activity and encouraging people to find things that challenge them, that give them that feeling of being challenged mentally. And if possible, that there's some nice options where you also have the socialization aspect, which we know has additional benefits to health and longevity. So thank you. That was really helpful. And I hope that our listeners got some helpful clinical pearls and tips and tricks that they can work on with their patients. And as always, we're really happy to have you be part of the Dementia Care Aware program and help us learn and grow this network. And we really hope that anybody who's listening also reaches out if they have questions or additional thoughts about this topic. And so thank you. I want to thank you today, Ian, for your time.
Definitely. Thank you as well. It's been a pleasure talking with you today.
Thank you for listening and to our wonderful guests. And a big thank you to our administrator and everything doer, Rita Archikova. Also, thank you to our audio editor and voice specialist, Lisa Costello. And we want to make sure you can get CE, CME, and MOC credits if you go to our website and click through to the podcast page, where you can do a quick quiz to claim credit. This is all possible through support from the California Department of Healthcare Services and the hard work of the Dementia Care Aware team. If you want to learn more, please visit our website, dementiacareaware.org.